So exam is next time we meet, and study guide's up to date. Info learning path is also up to date, so I think you guys are all set with the parameters. It's just now make sure you feel comfortable when you come in. Rehearsal is always good. That's what the old practice exams are up there for you, because you can use that to rehearse, and rehearsal helps a little bit with the nervousness of an exam. So don't forget to do that a couple times. Find out your weaknesses and shore them up before the exam actually occurs. Okay. Now we are going to finish up this chapter, and then we're actually going to go into the muscle chapter after this. Let's take a look at some synovial joints. We're going to look at the knee, the hip, and the elbow in a little bit more detail. The knee is an interesting joint. It is the largest joint in the body, and as our notes say here, it is actually the most complex joint. It allows us flexion and extension. And you get a little bit of rotation when you actually have slight flexion. This is what you do when you're doing various sports activities, football or something along that line. It allows you to do that pivoting action that you actually can see. So that's a little bit of rotation with that slight flexion, and allows that pivoting to occur. We have lots of bursa with the knee, so many bursa. And it is actually 3 joints in one. So the one joint is the knee joint, but there's actually 3 joints. And remember, the joint is where 2 bones come together and articulate. Now, articulation can mean we have lots of range of motion, but not necessarily, right? Because we have those 3 arthroses that are part of any sort of potential joint that you have. So what are some of the bones? So name one of the 3 joints that I'm talking about. Between what bone and what bone would be a joint? So what bone and what bone? Tibia and fibula. That's all right. Hey, I learned it that way too.
I usually say it in my head that way.
Yeah, I know. I learned it that way too. It took me a long time to unlearn the incorrect thing that I learned. So the tibia and the fibula. So that's this joint right here, correct? Okay. Where's another joint? So you can only answer one. The femur and the tibia, absolutely. We have medial and lateral condyles, and so here's our lateral and medial aspects for the menisci that are there for that articulation. So that's a joint. Fibula does not articulate with the femur.
Tibia and fibula.
Yep, that's that one right here, tibia and fibula. There we go. That's right, the femur and the patella. This guy here, and then he's going to articulate in this little groove area there. So yes, you guys found it. So we call it the knee joint, and we think of it as a hinge joint, and a hinge joint is also a uniaxial joint, correct? And so that's what we have here, but it's a little bit more complicated when you look at it in a little bit more detail. So that's why I say we have 3 joints in one, and when you have more than 2 bones coming together forming a joint, it's kind of called a compound joint. Just like we have a compound microscope, we have different magnifying lenses that actually allow us to see our object under the microscope. So this is actually an example of a compound joint. We have a lot of reinforcing ligaments with this. We have the fibular collateral ligament, and it actually has another name. Lateral collateral ligament, good. And then we have our tibial collateral ligament, and based upon that, the other one would be called medial collateral ligament. So those are are extracapsular ligaments designed to help reinforce that joint space. But we also have some intracapsular ligaments that are also there to reinforce the joint space. And that's what the ACL is, and then the PCL. So I've scribbled a lot all over this, and I'm going to erase my scribbling now. So the picture looks halfway decent. But those are some of the very important ligaments that help stabilize this joint. And whenever we have a knee injury and we have tears of some of the ligaments of the knee, what's the ones that are most commonly torn? Do you guys know? ACL. People hear about ACL tears all the time. Skiing accidents, football accidents. And also if you were in playing football and you underwent a procedure called clipping. Do you guys know what clipping is? When they hit your knee from the side? So what will that do to your knee when you're hit from the side with a big, I don't want to say big fat football player, but that's about what I was on, with a big husky football player? What is that going to cause damage to? It's going to cause damage to the medial collateral ligament, right? Because if you're hit from this side, that means that you're going to bend like that, which means that this ligament here is subject to tear. So now you are actually much more knowledgeable about the anatomy of the knee and the potential injuries that you can actually have with the knee joint itself. And so the knee bears a lot of weight, yes. And so because it's bearing so much weight, we have to add, and we actually have more than just flexion and extension mobility. We have that pivoting action that we can do. You have to have a lot of reinforcing ligaments for the knee in order to actually keep it quite stable. So that is a very important synovial joint. Two other joints we're going to take a quick look at here are the hip joint. That is a ball and socket joint, and it is indeed very deep and stable. And to help stabilize it, because indeed is also designed for weight bearing, unlike our shoulder joint, which is a ball and socket joint, it has several extracapsular ligaments to stabilize it. We do this for stabilization. It even has an intracapsular ligament, the ligamentum teres, or also referred to as the ligament of the head of the femur. Remember that little hole that was in the head of the femur? It was called a fovea. That is actually where that ligament actually attaches to that to help keep that in. And so when somebody has repetitive hip dislocations, this is indicative that that ligament has actually been torn, and other ligaments have become too lax to keep the hip in that socket nicely. So, fortunately, that one doesn't dislocate that often. The shoulder will dislocate a little bit more often than the hip will. And that's because the shoulder is got, its joint space is actually very shallow and the hip is nice and deep. The elbow joint is considered relatively stable and smooth because it also has several ligaments to actually reinforce it. And these are extracapsular, as we can see here, the radial collateral ligament laterally. And it is also 3 joints in one. So we have another compound joint. And now I want you to work with me and figure out what 2 bones are involved in the 3 different joints that we actually have here. So start off with the humerus and the ulna. And that's a pure hinge joint, right? Okay, and what else do we have? The radius and the ulna. That's what we call proximally, it's a pivot joint. And then what else do we have? Radius and humerus, that's right. So all 3 joints are having their own articulations involved. The interesting thing that you actually have to realize is that the radius and the humerus, is that really a pure hinge joint? Think about that. If it was a pure hinge joint, would you be able to do this supinate and pronate as you were flexing and extending? This is a little bit more of an interesting aspect of what we would call a gliding joint. Isn't that head of the radius gliding over the, do you remember the name for what we articulate on the humerus? Capitulum, because the trochlea is what we're articulating with for the ulna. And so that nice disc space that you actually saw, disc surface that you saw on the head of the radius is literally gliding over that nice area and able to glide and rotate and do all sorts of actions over that. So that's an interesting example of a gliding joint. Let's take a look now at some homeostatic imbalances or some problems that we can encounter with the joints. Sprains, cartilaginous injuries, bursitis, tendonitis, and finally arthritis. Sprains, when we say we have a sprain of a joint, we're talking about ligaments. And the ligaments are either stretched or torn. And that's why they can grade a sprain, because you can have a grade 1 ankle sprain versus a grade 4 ankle sprain. And which one do you, in your mind, would be considered worse? 4. And so what does that kind of tell you when you hear something like they said somebody had a grade 4 ankle sprain? That something was torn. And what is the chance of that healing? Yeah. So if you have a stretch versus a complete tear, the stretch will heal, but what about a complete tear? That's a surgical procedure, because one of the things about ligaments, they are very, very slow to heal. And we know that because of the vascularity associated with it. Within the tissue itself, it's avascular. So the only nutrient supply comes from what I call the paraligamentous area around that. And so if it's completely torn, then you've actually completely disrupted any sort of nutrient supply for any sort of healing. Cartilaginous injuries. Whenever you hear of cartilaginous injuries, we mostly think of the knee cartilage. There's other areas where we can have cartilaginous injuries, but let's just stick with the knee cartilage. What do we know about how well cartilaginous injuries of the knee actually heal? Because this is tearing, not stretching, because cartilage doesn't really stretch. It wasn't designed for that unless it's elastic cartilage. And then it would be an injury, right? This is an injury. So we've actually torn the cartilage. And do people who have torn menisci, do they do fine without any sort of intervention? No. They have to actually go in and actually get the flap of cartilage that's flapping around in their knee actually surgically removed. Otherwise, they feel that catching all the time and are unable to actually utilize that joint fully. So they rarely repair. On own, and that's because we know about their vascular nature. They are avascular. Now, bursitis and tendonitis, you guys all know itis means inflammation of. And so we have inflammation of bursa or tendon sheaths with this. And some examples of bursitis would be housemaid's knee, or student's elbow, and so housemaid's knee is typically referring to an area that's pre-patellar in front of the patella, okay, and student's elbow, that's typically referring to that area that would become inflamed whenever it is repetitively used or traumatized. You guys use it a lot, so repetitive use, I've never known repetitive use to actually hurt an elbow, and so it's more of a traumatic event where it's been kind of pounded down onto a surface itself. Trauma is the typical agent that does this. That's usually, but is it always trauma that causes itises or inflammation? So infection could be also another cause. It's not the most common cause. The most common cause of our bursitis or tendinitis are actually trauma-induced, and repetitive use can actually be considered a trauma. I actually prefer to call students' elbows Popeye elbows, because when I say Popeye elbow, everybody actually, does anybody not know who Popeye is in here? Even if you don't know who Popeye is, you probably don't want to raise your hand. But Popeye elbows are, it looks like he's got a drop hanging from his elbow, doesn't it, from his olecranon. And that is actually student's elbow or Popeye's elbow. And I've actually seen that. And they come on in, and that's was very hot, red, and inflamed. And do you suppose that I put a needle in it and drained it off before I thought to do anything else to it? Absolutely. It's easily accessible, and when it's big and swollen like that, draining off the fluid is actually going to give you some pain relief, and then you can actually have the fluid analyzed to make sure it's not infected in your methods of treatment after that. It's hard to believe with arthritis there are actually over 100 different types. And it is truly amazing because the different types will vary how you treat them and actually how they'll respond to treatments. There are only 3 types that I ask you to know for this class in the upcoming exam, and that's osteoarthritis, which is the most common type, rheumatoid arthritis, which is an autoimmune disease and a very chronic inflammatory disorder, and gouty arthritis, which is genetically induced. Let's start with osteoarthritis, the most common. We call that the wear and tear arthritis, but there is actually a lot more to it because women are affected more than men. And I know who has more wear and tear on their joints of the 2 sexes. Wouldn't you say it's men that actually have more wear and tear on their joints than women? They actually are much more in what I call the heavy labor types of careers. And so it's interesting that we say it's a wear and tear arthritis, but there's more going on than just that. What's interesting, inside the joint space, so there is an enzyme that is being released in the synovial fluid that actually causes cartilaginous damage faster than the cartilage can repair itself. Remember, cartilage is avascular, but it's still living tissue, and the thickness of the cartilage is limited by your ability to actually get nutrients to diffuse into that area. So you can damage cartilage a little bit on its surface, but you can also cause repair of that damage. However, in osteoarthritis, the enzymatic action for some reason is much more aggressive and starts eating away that surface cartilage, and those little chondrocytes cannot actually facilitate a repair process fast enough as it is eaten away. Now, when cartilage is eaten away, what is then exposed? Bone. And so bone gets exposed, and now bone is actually experiencing what I call trauma, because instead of now being covered up nicely with that articular cartilage, the bone is exposed, and anything that's going to happen with that joint, which is activity related, is going to start pounding on that bone. When you start pounding on bone, what happens? What does bone do in response to that action? Will bone break down when you start pounding on it? Actually, bone does the opposite. Right, bone actually increases. That's, remember, one of the reasons, one of the things that you want to do to prevent osteoporosis is what? Exercise. Be active. Give bone a good shaking up. You know, shaking your bone keeps the osteoblast active more than the osteoclast. But if you start to remove a cap over that bone will experience trauma or drama, and it will actually respond to that, and bone will grow. So we get bony spurs with osteoarthritis. And this causes an enlargement of the bone ends, and causes some difficulty, obviously, then with movement or articulation between those areas. This is a slow course or progress of this disease type of process, and it is irreversible. Now, some people who start to have problems early on when they feel that their joints are uncomfortable whenever they move can actually take over-the-counter supplements. Has anybody heard what type of over-the-counter supplements people will try to take for their joints? Glucosamine. And it's just glucosamine sulfate. It has been known to help some people. And the reason it helps some people is part of the matrix of cartilage has glucosamine in it. And so when you take a supplement, glucosamine, that actually can help replete some of the matrix of cartilage, because that's part of our problem with osteoarthritis. Enzyme action is destroying the cartilage faster than our chondrocytes can actually repair it. So taking glucosamine sulfate for some people actually seems to help their little chondrocytes do a little bit better job, or their chondroblasts do a little bit more work. Now, this process, do you think it happens, if it's going to work, do you think it happens overnight? No. This, remember, anything slow to repair, if you're going to see any improvement, it's going to take a while to actually occur. So those lovely bottles of glucosamine sulfate typically have a lot of pills in them, and you actually, if it's going to work, you probably will know it by the end of the bottle whether or not it's time to go out and buy another one of those. The chondroitin doesn't seem to actually help. Studies have been done over and over and over again. And you have to understand that the one that's actually been shown is actually the glucosamine sulfate, and it takes some time to actually work and will not work for everybody. So what works for one doesn't necessarily work for another. Let's take a look now at rheumatoid arthritis. Indeed, it is a chronic inflammatory disorder. It is autoimmune. In other words, your body is causing this problem. It can be triggered, the autoimmune response, or the thing that triggers the autoimmunity, can be either streptococcus or a virus. What happens is joint destruction occurs here. It starts off unilaterally, but eventually becomes bilateral. Also, women are more affected than men. This is one that you actually can see with what is called, I'm going to hold my hands out straight, with my palms down, and I'm going to say you can tell somebody may have some sort of arthritis going on, and you wonder if it's rheumatoid arthritis, if you actually see what's called ulnar drift. So ulnar drift, what would I do with my hands? Would I move my hands towards my thumbs or would I move my hands in the direction of my pinky? And my pinky. And so at the MCP joints, those joints, instead of being straight, will be drifting off to the lateral side. And so that's a very common problem seen for people with rheumatoid arthritis. And you can see this would make for a lot of difficulty with grasping, correct? And so they do have a lot of problems with their hands. If it's an autoimmune problem, the treatment that they use is actually chemotherapeutic agents that actually is designed to attack or inhibit the immune system. Gouty arthritis, that is due to excess uric acid. And take a look at what it does. It creates crystals in your joints. What's so unique about a crystal? Crystals have sharp edges. So let's put a bunch of razor blades in your joint, something with sharp edges. And what will that do for you? It causes a lot of joint damage. And that's basically what gouty arthritis is all about. Gouty arthritis is a lot of sharp crystals precipitating out in the joint space, causing significant damage to that joint space itself. This one, it's the guys that are more often affected than the gals. And this is because men have a larger body mass and muscle mass. Because uric acid is a byproduct of various protein metabolisms associated with our muscles. The interesting thing, you can actually think that somebody may actually be having their first attack of gouty arthritis if at the base of the great toe it becomes terribly painful and swollen and affected. People who get rheumatoid arthritis have a little bit of a genetic tendency. It kind of runs in families. Same thing with gouty arthritis. Has a genetic tendency, runs in families. And so there are ways that actually you can make gouty arthritis more likely to occur. And there's things you can do if you have a family history of gouty arthritis where you can actually try to not have your first attack. And if you avoid purine-rich foods, and some purine-rich foods are liver and kidneys, sardines, and alcohol. Alcohol is not a purine-rich food, but alcohol, excess alcohol intake can actually precipitate a gouty attack. People who have gouty arthritis, they want to stay well hydrated. And that's where the alcohol comes into play. Because when you drink a lot of alcohol, what happens to your hydration status? It goes down, you become dehydrated. And it's always interesting, somebody that's out on Lake Coeur d'Alene on a hot sunny day, out on the boat, drinking a lot of beer. And then they suddenly have problems with the base of their great big toe. And so right off the bat, you know they got dehydrated, the alcohol exacerbated it, and they were probably eating some other stuff out there that caused their problem. So gouty arthritis is an interesting arthritis. And if it runs in the family, you just kind of eliminate some of these things from your diet and just make sure you don't ever get terribly dehydrated when you're outside playing in the sun. Because you should still, in my point of view, you should still be outside playing in the sun. Yes?
What is purine?
Purine? Purine and pyrimidines are actually part of our DNA and RNA, so they're actually part of nucleic acids. But a good question. Let's go to the next chapter, chapter 9. We're now into muscle and muscle tissue, and you guys know there's 3 different types of muscle tissue. We have skeletal muscle, which is attached to the skeleton, designed to move the skeleton. We have cardiac muscle, which basically forms the wall of our hearts. It's actually part of our pump. And then we have smooth muscle, which is every place else where we actually find movement involved. And so often you'll hear in the walls of hollow organs. So blood vessels are hollow organs. Your stomach and your intestinal tract are hollow organs. Bladder also, and urethra and things along that are also considered hollow organs. You can easily tell from these histology pictures which one is which. We have 2 that are striated, and one is heavily striated. The heavily striated one is skeletal muscle. The lightly striated one is cardiac muscle, and smooth muscle has no striations whatsoever. The other thing about cardiac muscle is those cells are shorter, and they have a unique feature that is typically seen easily with the microscope, and that is the intercalated discs. And these are our intercalated discs right here. Cardiac muscle is also typically uninucleate. That means there's only one nucleus. Also in smooth muscle, we have just a nucleus per cell. Smooth muscle cells are long tapering cells. And when you take a look at some smooth muscle tissue, you see a very nice linear pattern of the muscle cells. And a lot of times it looks like another type of tissue if you don't look at the nuclei. What other tissue would this look like if you actually kind of omitted the nuclei? Dense regular CT. So whenever you are looking at tissue slides and trying to determine is this smooth muscle or dense regular CT, you actually try and say how many nuclei are here and do they look like they are associated with what would be one cell versus another cell versus another cell, and that would be smooth muscle. Skeletal muscle have a lot of nuclei per cell, and that's because a skeletal muscle cell runs the entire length of the muscle organ. And so a skeletal muscle cell is pretty darn long if you think about that. And if you're going to be that long and as thick around as they are, you need a lot of help in actually maintaining that. And so we have all kinds of nuclei associated with these guys. It's not a very good circle around that one. But this is a nucleus with this cell, this is a nucleus with this cell, and I'd say that this is a nucleus with this cell, and this looks like a nucleus associated with that cell. So there are a lot of nuclei, and they are peripherally placed, correct? And that's because all of the stuff that's inside a skeletal muscle cell is pushing the nuclei off to the actual exterior zone of that cell itself. Now, there's some other nuclei here in this picture, and that doesn't look like a nucleus that's associated with that cell. What would you think that that nucleus is actually associated with? Just taking a look at that, and I'll make it go away so you can take a little better look. Connective tissue. Remember, connective tissue holds organs together, and so when you have a lot of skeletal muscle cells, you actually need to have a scaffold that actually is going to keep those cells in place, and we're going to talk about that in just a moment. So very good call on that. So that's a nucleus of a fibroblast. Some things about skeletal muscle cells: they have these 4 special characteristics. They are excitable. You can stimulate them and they will react. They have contractility. Part of their reaction is their ability to shorten. Extensibility. You can actually stretch muscle cells. Now, you can only stretch them to a certain amount, and the ones that stretch the most, the best, are smooth muscle. Smooth muscle has the capacity to be stretched a lot, and that's definitely exhibited by your bladder, right? Think of your bladder. Think of what it's like a balloon, and then it gets filled up with water, and the muscle cells aren't changing. You know, we aren't getting more muscle cells or less. So those are the ones that have the highest stretch or extensibility factor. The other thing, too, is they have that elasticity. And remember, when I talk about elasticity, I talk about recoil, the ability to return back to your original length. As far as functions, we have also these 4 functions. Produce movement. Skeletal muscle produces movement of the skeleton. Cardiac muscle actually produces movement of blood. Very good. Blood vessels, which are smooth muscle, also produce movement of blood. But let's actually now say movement of things through tubes. For our smooth muscle. What muscle is involved in the maintenance of posture and body position? Skeletal. What muscle is involved in joint stability? Skeletal, absolutely. And then what muscle do you suppose is responsible for most of our heat generation? It actually is skeletal. So skeletal is in every single one of these functions, but not smooth muscle or cardiac muscle. So heat generation is indeed a skeletal muscle phenomenon. And it actually makes up about 40% of our body weight. And contributes to most of our heat generation. I'll say production, PDTN, because it's shorter than generation, production. Let's take a look at skeletal muscle tissue, and our cartoon here is an interesting one. It shows a muscle that's attached to, what is this area called? You had your bony valve, right? Trochanter, that's the greater trochanter. This is the lesser trochanter. That would be the intertrochanteric line in that view that it looks like it's attached, because it's hard to tell that it's attached to the lesser or the greater trochanter. Now, with our muscle, this is showing you the muscle organ. Gross anatomy of skeletal muscle organ. Because this whole thing here is the organ, and we've kind of sectioned it off to kind of show the smaller bits and pieces of it. One of the things that we do know about all of our skeletal muscles, they have a great nerve and blood supply. So great nerve and blood supply, rich is an excellent term for that. And in general, we'll have one major artery plus one plus major vein plus one major nerve supplying them. So supplying one muscle organ. When we take a look at the muscle, we see it is attached to bone, and we know the bone attachment is called the tendon. But the tendon, if we follow its fibers, actually starts to separate into different CT compartments. We have some CT from that tendon that actually is also found around the entire muscle organ, and we call that tendon that's around the entire muscle organ the epimysium. And then as we follow and dissect that tendon out a little bit more, we find that tendons are also around, CT is actually around a muscle cell, and so we're going to call that muscle cell another name. It's called a muscle fiber, and that CT that's wrapping the muscle fiber is called endomysium. Remember, endo is always kind of the most inside that you can get, so endomysium. So we have epimysium on the outside, endomysium around individual muscle cells that also have another name called muscle fiber. And then we actually have another mysium called perimysium, and that's because we have a bundle of muscle cells. So perimysium actually encircles various bundles of muscle cells. And so when you cut across your meat and you see fibers, what is it that you're actually really seeing when you take a look at the grain of the meat? You're actually seeing perimysium, because what you're seeing is a whole bunch of muscle cells, and that's a group of them, and the reason you see them so nicely is because there actually is that nice CT that's kind of defining them as a group. So that cross cut that you see, those are not muscle cells, those are fascicles. So those are fascicles with the perimysium around them. And that's what you're actually experiencing. In our notes, it's reiterating the endomysium surrounds each muscle cell. The perimysium surrounds a group of muscle cells called a fascicle, and then the epimysium helps to envelop the entire muscle organ. All of that CT all coalesces to form the tendon. Now, let me ask you about the arrangement of the connective tissue of these. At the tendon, how is the arrangement of the fibers in that CT? How are the fibers in the CT of the tendon arranged? This is actually something important for even histology. That's coming up too, isn't it? Is it irregular? Regular. Isn't a tendon, isn't the fibers arranged in a regular pattern? Okay. So we have a regular arrangement of our collagen fibers when we're at the tendon aspect. But what do you know about a muscle? Does a muscle always stay the same size? No. So when a muscle contracts, what is the thing that you notice about its size? Its girth. Gets bigger. So let me ask you now, what would the arrangement of those collagen fibers be like in the body area of the muscle? Irregular. So what you have to realize is because of the function, the structure actually rearranges itself in order to accommodate what it actually is required to do. At the ends of the muscle, those collagen fibers become very parallel because it's kind of just a pull in that one direction. But when you actually go and follow those collagen fibers around the muscle organ and through the muscle organ itself, you'll find that those collagen fibers are still collagen fibers and fibroblasts, but they'll change their arrangements because of the type of stress that's being applied to them. And so that's an important process to actually realize. When a baby is born, do you suppose all of its tendons are very linearly arranged, very parallel in its arrangement? When a baby's born? No, because the baby hasn't had to really fight against gravity, right? And pull and develop those muscles. And so as time goes on, this arrangement becomes more obvious and shows you the actual function that the organ is actually undergoing. Now let's take a look at the next aspect here. Because we talked about the tendon, attachments to bones, and tendon can actually attach to other structures. And when we talk about the attachments of a muscle, and also when we talk about a muscle's length, are we talking only about the muscle cells that you can see or the muscle organ that you can see, or are we including the tendons in the length of that muscle? What do you guys think makes the most sense? Because are the tendons part of the muscle? Yeah, they are part of the muscle structure. So the tendons are part of the muscle. And so when we actually take a look at a muscle's length, you have to realize you look at its length from tendon to tendon. And it's the end of the tendon where it's attached to whatever structure it is. And so we have some definitions here that you have to remember. And it can vary based upon what is being stabilized. But let's go with the very broad definition. Origin, attachment point to the less movable bone, and insertion, attachment point to the moving bone. Now, when it's the pectoralis major, its attachment is to our sternum and a little bit of our clavicle. And these are movable or immovable bones. They're immovable bones. And then the pectoralis major is also attached to the humerus, close to the head of the humerus. And that is the movable bone. So the origin of the pec major is the sternal side of things, and the insertion of the pec major is the humerus. And so that's what we're talking about when we talk about origins and insertions. But sometimes in other areas, you can actually fix your hips and then move your spine, correct, in relationship. But when we typically talk about this, we talk about it in what is most typically done. So if we're talking about a muscle like the iliopsoas is a muscle that's kind of inside your body. You'll find it on your cat in the area of the hip area on your cat, but it attaches to the vertebral column and the iliac fossa and comes out and attaches to the femur. And it is responsible for hip flexion. And so its origin is internal where you can't see it, the vertebrae in the lumbar area and the iliac fossa. Its insertion is at the femur. But if you were actually on a device at a gym where you were bent over and extending yourself, those origins and insertions would be considered changed. But is that the usual thing that you do? You usually have your spine as the fixed thing, and then the appendages, your legs and your limbs are the attachment points. So keep that in mind when you try and figure out origin and insertion. What is meant to move the most often? Now, if your tendon is attached to a bone, it's called a direct attachment. And when it's attached to the bone, it's attached first to the periosteum, correct? Because the tendon, the periosteum is dense, irregular CT. So isn't that interesting? The muscle itself is dense, irregular CT. The tendon is dense, regular CT. And then the periosteum is dense, irregular CT. So it's kind of like it forms a bridge. And actually, that's what it does. It's forming a bridge between these various areas. When the tendon is not attached to the bone, and therefore the periosteum of the bone, it's called an indirect attachment, and it's attaching itself to various connective tissues. A perfect example of an indirect attachment is pecto-antebrachialis. So when you hear pecto, what do you guys think? Chest, right? You think chest area. And so I'll tell you, let's start with the sternum because that's the most common origin site whenever any muscle has its part of its anatomy attached to the pecto area. So it's a sternal attachment. Where's your antebrachium? That's your forearm, yes? And so you're going to find a very superficial muscle on the cat that you're going to be dissecting out called the pecto-antebrachialis. That's part of the cat's pectoral muscle groups. The cat has 4 pectoral muscles. The human has 2. We have pectoralis major and pectoralis minor. Cats have that too. They have pectoralis major and pectoralis minor, but they have another one called xiphihumerales. And where's your xiphoid process? At the bottom of your sternum. So xiphihumerales going actually up towards the head of the humerus area. And then they have one called pecto-antebrachialis. And these muscles are important for the cat to use because the cat differs from the human in a very important way. The human is a biped, the cat is a quadruped. And the cat doesn't go like this very often, does it? The cat is more like this, with the upper extremities or upper limbs out there in a normal stance pose. So if you have a pecto-antebrachialis, won't that kind of nicely stabilize things for you? And then a xiphihumerales will help you with all those lovely climbing maneuvers that the cats do. So they have some muscle modifications because they are a quadruped. but they still have some of the very same muscles that we actually have as a human. Now, when it's attached to the antebrachium, I want you to realize it's attached to the connective tissue of the antebrachium. So if you dissect it off, you've actually removed an insertion site for that muscle. When you're in the lab, part of your muscle eval is paying attention and keeping the muscles attached to origin and insertions. So always attend to the antebrachium last in your dissection work, or close to the last, so that you can actually preserve the insertion site, and realize it's important to actually preserve that muscle's insertion site as you dissect. That's just a little bit of dissection advice. Microscopically, let's take a look at our skeletal muscle tissue. So we were previously talking about organ, now we're into skeletal muscle tissue. Skeletal muscle itself, tissue, it's interesting because everybody likes to give things a different name. It's kind of like nicknames, you know. After a while, you wish that people didn't have nicknames, just like you wish that we didn't have a tendency to name something so many different things and actually be referring to the same thing. But when you hear the word sarco, you automatically think muscle. And sarco is much more, it's going to be common to all muscles. So sarcolemma here is going to be the name that we will give a muscle, a skeletal muscle cell's membrane. But the sarcolemma is also going to be cardiac muscle cell membrane and smooth muscle cell membrane. So sarcolemma is muscle cell membrane. The first sarco that you should think this applies to, though, is skeletal muscle. So sarcolemma and plasma membrane are the same thing, or cell membrane. It's just now everybody knows we're talking about muscle tissue. And so sarcoplasm is cytoplasm of muscle cells. And so we actually have that there for that. And what's interesting about the sarcoplasm of our muscle cells is they have a lot of glycogen in them. You guys know what glycogen is? Sugar of tissue, of mammalian and other tissue. So glycogen is the cell's storage form of sugar so that it can be used when we need it. So it's our reserves. The other thing that we'll find with our muscle cells, besides sarcolemma, sarcoplasm, and glycogen, is this protein called myoglobin. Myoglobin sounds like hemoglobin. And what is hemoglobin designed for? Transport oxygen. And that's another thing that we actually have with myoglobin. Myoglobin is inside the muscle cells. It's a protein that is designed to store oxygen. And this is because muscle tissue can become very active in a short period of time, especially skeletal muscle. And so as the activity level increases, it will start actually using the oxygen from its own myoglobin as it needs it if the circulation is not keeping up with the tissue demands for oxygen delivery. Now here's another name that we have for a muscle cell. It's called a myofiber. So myofiber equals muscle cell, and also for right now, I will sometimes say just fiber. So myofiber, muscle cell, and fiber are three synonyms, all referring to one thing. Our picture down here, we have a cartoon and we have another histology thing, and we see a lot of striations in skeletal muscle. And the dark bands are going to be called A bands, and the light bands, that's what striations are, dark light, are going to be called I bands. And we're going to learn all about sarcomeres in just a little bit. Here we have the word fiber. Up here we had myofiber and also muscle cells. So realize they're all the same thing. As we take a look at this picture right here, realize we are just looking at a small segment of a muscle cell because it runs the entire length of the muscle organ. And we also see the nuclei. They're multinucleate, and we already discussed that if we actually see a nucleus that we can't figure out what it belongs to, like this guy right there, that nucleus probably belongs to a Fibroblast because of what's around the muscle cell? Endomysium. Endomysium is connective tissue, right? And so if you're going to have connective tissue around a muscle cell, you must have fibroblasts there to help maintain that connective tissue around that. Now, our cartoon does not have any endomysium here, but it does show you the sarcolemma, and it's trying to show you that they're peeling it away to look at this cartoon rendition of what's inside a muscle cell. And so we see our nuclei here and then under the sarcolemma here and here. And I don't see anything that looks like what I would call cytoplasm in this view. Do you guys see anything that you would say is cytoplasm? But it's in there. So it's been kind of left out. And it would be the fluidish-like material that's around these Lincoln logs. To me, it looks like this is full of Lincoln logs. You may not know what Lincoln logs are, but they're these truly log-like materials that we used to play with when I was a kid and make log structures, log cabins and stuff along that line. So we've got this nice collection of logs inside here, and they have a name called a myofibril. Well, we just said a muscle cell is a myofiber, and now they're full of myofibrils, and these are proteinaceous units, these myofibrils. We have myofiber, and we have a myofibril, and then we have myofilaments that make up myofibrils. So a myofiber, let's go up here, runs the entire length of the muscle cell. A muscle organ, excuse me. And a myofibril also runs the length of the muscle cell. Which is another way of saying it runs the length of the muscle organ too, correct? If a muscle cell runs the length of a muscle, then and a myofibril runs the length of a muscle cell, it must be running the length of the muscle itself, and is made up of these lovely things called myofilaments. So a myofibril is protein. Myofilaments also are protein, but we have two types of myofilaments. We have actin as one of the myofilaments, and then we have myosin as the other myofilament. At this time, take a look at the other synonym that we actually have for actin. We have thin filament, and for myosin, we have the term thick filament. How do you remember which is which? Well, I'll tell you what works for me, and you can use it if it works for you, and if it doesn't work for you, come up with something else. Look at the length of the word myofiber, myofibrils, and myofilaments. The shortest one is the cell. The one in the middle is the next level, and that length of that word myofibrils is not quite as long as myofilaments, correct? So if you kind of keep it in that order, myofiber, that's the cell, and myofibril would be the Lincoln logs inside the cell, and myofilaments would make up structurally the myofibril, or the Lincoln log. Because the Lincoln logs were made up of also subunits itself. These are all protein strands, and the other thing too to also see is we can also call a myofibril a fibril, or a myofilament a filament. And that's because we get lazy, right? It's just easier to say filament than myofilament. Now, a sarcomere is a structural and functional unit of a muscle cell. And a sarcomere involves overlapping myofilaments. how they overlap creates a pattern. So a sarcomere is a pattern. And how you see the pattern of the overlaps of the myofilaments will give you the overall pattern that you see in the actual myofibril and therefore the muscle cell itself. So let's take a look at our thick filament down here and then how our thin filaments overlap with our thick filaments, and then look up here at the other cartoon type of drawing. We have an area that's called an A band. And when you take a look at the limits of the A band, it is due to myosin. Now, myosin is thick and actin is thin. And so when you actually shine the light up, as you guys are looking at these on a slide with your microscope and the light is shining up through that, the thicker filaments will allow less light through them, correct? And that's called the dark band. Less light means dark. Then the actin filaments themselves are thin, and because they're thin, they will allow more light to actually pass through that small section of tissue. And we call those areas where we actually see more light going through the tissues, we call those guys I bands. So that's an I band. So an I band is just actin, correct? When you take a look at this cartoon, isn't it just actin? I band to I band. When you take a look at the A band, it is myosin for sure. Is it only just myosin as you take a look at the picture? There's a little bit of overlap of the actin with the myosin, correct? And so the A band is indeed definitely due to myosin, but there's a little bit of overlap of actin, and because of that, the in-between area where there is no overlap, we actually have another lighter area, and that's called the M line. A sarcomere actually has a tethering site within it, and the tethering site is in the I bands, and it's the middle of the I band in this area called the Z disc. And so as we take a look over here at this Z disc, I want you to realize the only thing I really want you to take home and remember about this is that actin is tethered to a Z disc. And the Z disc is in the middle of the I band. Now, the Z disc is not like a fence post in the ground. I want you to realize the Z disc is like a fence post that's not in the ground. Say we have some barbed wire attached to a metal rod or a fence post, and the fence post is up in the air. It's not attached to anything, but the barbed wire is attached to the fence post. That post is the Z disc. And that's important that you realize this, because when we talk about the sarcomere shortening, I want you to realize that the Z disc is not tethered into the ground. It's not in any sort of structurally immovable area. So the Z disc is just a tethering area for actin. I am not concerned about what myosin is tethered to. I am concerned that you remember actin is tethered to a Z disc. So you don't have to memorize what myosin is tethered to, but myosin stays right where it is all lined up. So there is something stabilizing myosin, but it's not important that you know about the stabilizer for that. In our notes it says Z disc, ends of a sarcomere unit. So a sarcomere is from Z disc to Z disc. That is a sarcomere. Thick filaments are myosin. Thin filaments are actin. let's take a look for a moment at what makes up the thick filament. It is truly all myosin protein, but the myosin protein looks a little bit like a golf club. So down here is an individual myosin protein, and it has kind of this head where binding sites are located. And it's like a double-headed golf club. And then when we take a look at the thick filament, it's like somebody grabbed some golf clubs and the heads are off on different directions and they're all grabbed right in the center of that. So that we actually have at the, that's what this is actually meant to show you. All these little nubbins right here, those are kind of like trying to show you the myosin heads off to the side of this thick filament. So it's all the way around that thick filament, these little myosin heads. And the actin binding sites are on the myosin heads, and there are also ATP binding sites on the myosin heads. So these two things are actually important. We'll talk about the importance in just a minute when we actually, well, next time when we actually lecture about the sliding filament theory. Now the thin filament is 3 different molecules. So myosin is just one molecule. The thick filament is only one molecule, and it's got a whole bunch of them actually bundled together. The thin filament is 3 different molecules, and the 3 different molecules that we have are actin, tropomyosin, and troponin. Actin are what they call the beads. To me, they look like olives. So 2 strands of bead-like actin proteins that have on them also a binding site for myosin heads. So when actin and myosin are able, they actually can bind together, but that's not what we're going to get into yet. But actin, bead-like actin proteins, 2 strands of them. Then we have this thing called tropomyosin, that brown thing, a thread-like protein that reinforces the thin filaments and blocks the binding sites on actin when the muscle is relaxed. The other protein that's actually part of the thin filament is called troponin. And it's, again, another protein. It says a globular protein that is bound to actin, tropomyosin, and calcium when the muscle cell is contracting. So A plus T plus Ca when muscle is contracting. Troponin reversibly binds calcium. So when the calcium is present, it will bind to troponin. And we're going to learn a bit about what this binding actually does. Again, we're back to the sarcomere. The banding pattern is due to sarcomeres. It's due to actin and myosin filaments and how they overlap. That's what gives us the nice striations. Again, here is the A band. And we can definitely say in our notes, the A band is a dark band. It is for sure myosin. And plus some overlapping actin. The I band is the light band. and it is actin only. There is a Z disc in there, but the Z disc is just a tethering spot. A sarcomere goes from Z disc to Z disc. Again, it's just reiterating it, and it's okay to do that. And the Z disc is in the middle of an I band. The H zone is myosin only. And it's a little less dark than an A band, than the entire A band. So H zone is in the middle of the I band, and it is myosin only. An A band is for sure myosin, but part of its structure is actin overlap. And that's important because we're going to have interaction between actin and myosin whenever we have the muscle cell shortening or the sarcomere shortening. Sarcoplasmic reticulum is also called SR, sac-like membrane complex that stores the calcium that we actually talked about briefly. So SR, similar to endoplasmic reticulum. It is designed to control calcium ion levels inside the muscle cell. We'll talk about how it does that next time. So we'll stop here and do a couple clickers.